Right, might be a good time to start. Welcome as folks are still joining. Well, good morning and welcome to Coffee Conversations, an interactive discussion series hosted by the Academy of Communication and Healthcare. Hi, my name is Rakia Wangas and I'm a Senior Director for ACH. Today we are joined by our featured guest, Bob Smith. The Academy of Communication and Healthcare is a nonprofit academic community to support education and research in communication and relationships in healthcare. The topic for today's conversation is Medicine's Guiding Theory Shortchanges Patient Centered Communication in Mental Health Care. Unlike a webinar, these sessions are more like conversations and we will invite engagement. Our aim is to connect you with colleagues. Part one is an interview conversation with a featured guest. Part one is recorded and available in the ACH Connect member site. We encourage you to mute audio for part one so that we may minimize distraction. Video is optional. We invite you to use the chat feature with questions, reflections during part one. Part two involves interactive breakout groups where you are encouraged to share conversations with a few colleagues. We encourage you to start video and unmute audio for part two. Part two breakouts are not recorded. We hope you can stay for the entire hour and engage in part two conversations with colleagues. With that, I want to welcome our guest, Bob Smith. And while we're welcoming our guest, I'm going to ask you, Bob, to tell us about where you are located, your morning beverage of choice, and what your current and previous professional work entails. And while Bob is answering that question, if you would like to drop in the chat, those of you who are joining us, where you're located, your name, where you're located, and your morning beverage of choice, that would be great.
Sure, I'm Bob Smith. I know many of you, I'm sure. I retired from Michigan State in Department of Medicine and Division of General Medicine. Been interested in patient-centered interviewing for a long time, and more recently, over the past 10, 15 years, I've gotten interested in primary care mental health. If you think of it, when you're doing a patient-centered interview, you elicit personal information. It's often mental health information. And so we need to know how to deal with that. And that's the link between patient-centered interviewing and mental health that I'm interested in. Thanks, Rakia, for inviting me.
Oh, we're so glad to have you for this very important discussion. I'm curious, before we dive into the specific topic, of what brought you to your interest in communication in healthcare specifically?
Say again, Rakia.
What brought you to your interest in communication in healthcare specifically?
Oh, I was in practice for 10 years and realized how inept I was at interviewing and certainly in handling all the mental health patients that came in. And so I then went back to the University of Rochester and did a fellowship there and stayed on faculty. And then, since 1985, I've been at Michigan State. And that's where I got interested in research. We first did research on the patient-centered interview and developed the first evidence-based method for it, and that's in the textbook that we have that ACH uses. I then did, extending that work, did two randomized controlled trials on primary care mental health, and basically showed what we call the mental health care model could be taught to primary care physicians and other clinicians and effectively improve patient outcomes, not only physical, but also mental, and reduction in opioids and increased use of antidepressants and a host of other things.
Wow. So you made the point of the connection between the patient-centered interviewing and mental health care. What would you say is the problem with mental health care today?
Oh, the main problem with mental health care is it's almost non-existent. Tom Insel, the former head of National Institute of Mental Health, labels modern mental health care a human rights crisis. And with that, I mean, you have to understand that mental health care that mental health problems are the most common health problem we have in the US. It's more common than heart disease and cancer combined. And yet, only 2% or 25% of mental health patients, and we know who's out there from epidemiologic surveys, only 25% are receiving any care at all. That means 75%, 3/4 of all major mental disorders are being missed completely. They're not even recognized. And it gets worse. The 25% who are recognized are taken care of 80% or so of those by primary care and other medical clinicians who are not trained in mental health. And their care is demonstrably substandard. This is well recognized. And it's time to put the myth of psychiatry to rest. Psychiatrists see no more than 12% of all mental health patients. And so that has long been held to be the answer. It is not. And psychiatry residencies are decreasing, and the number of psychiatrists are decreasing. Mental health care is being provided by primary care people, and they are not trained for this. Now, what do I mean by not trained? Of all the thousands of hours in medical school and thousands of hours in 3 to 5 years of residency, less than 3% of total teaching time is devoted to mental health and other psychosocial issues, the types of things we elicit with patient-centered interviewing. And so, remembering now, mental health problems are the most common health condition in the US. Our medical system is not providing education to manage the most common health problem we see in practice. And you might ask, has medicine lost its mind? Well, that's the title of my new book. It's coming out in next March from Prometheus Books. And it is essential that we start to recognize the problem of mental health care in this country. It is substandard. It is not anywhere equivalent to medical care. And while I'm talking on here, Zekiah, so do you want me to move ahead and?
Sure. I'm sorry. I think I lost the audio a bit there, but yeah,
Oh,
please, you unpacked a lot there. And so I would love to hear more about what led to this current situation.
okay, good. So I said, has medicine lost its mind? Kind of rhetorically. But at a more serious level, has medicine lost its mind? The answer is yes, it did lose its mind. It lost it in the scientific revolution in the 16th and 17th centuries in what's called the mind-body split. What happened was that the mind was viewed as the province of the church, very powerful church at that time. And the body went to medicine and medical science. And so this originated in the field of anatomy. Anatomy then was the most basic of all sciences. Genomics and so on are important today, but back at that time, anatomy was the most important. But up until 1537, when Pope Clement finally allowed dissection of the human body, which is, of course, necessary for studying anatomy, clinicians had relied on goats, cows, pigs, and the like, and inferred erroneously that these changes were similar in humans. That was completely wrong. Well, at this point, dissections began, and the church finally relented and provided it. Now, get ready. This is a little grisly. But the church had one proviso. The church said the body must first be decapitated and the head physically turned over to us before the dissection can begin. Well, that symbolically established that the head the mind, the soul, the spirit was the church's province, and the rest of the body from the neck down belonged to medicine and science. And so what happened was that over years, this began, this idea of the body below the head belonged to medicine, went into physiology, chemistry, and the like over many years. And it established this long-term pattern. Then, now coming along much later, clinicians still were functioning the same as they always had, according to the old idea of the four humors. They were called blood, phlegm, black bile, yellow bile, the four humors. And it was believed since the time of Hippocrates in the 5th century BC that an imbalance of these humors represented disease and caused symptoms. Comes along pathology now in the mid 1700s, early 1800s. They already knew anatomy and what normal looked like. Now they're starting to find dramatically different changes. For example, a liver that was twice the size it ought to be, or in the chest, a chest, instead of having a lung there, it was full of fluid. And at that point, they realized that that big liver or that fluid in the chest was the disease, and that it was what was causing symptoms. That's what we today call clinical pathological correlation, and it's obvious to us, but it overturned this whole idea of the imbalance of humors. So, moving along then, it wasn't until the end of the 1800s, early 1900s, that clinical care actually improved. And at that point, things like so-called sulfonol was discovered for sleep and various other things. But it was really in the early 1900s that sulfa, penicillin, ether, chloroform were discovered. Dramatic changes occurred then in managing acute diseases and acute surgical problems. Dramatic changes occurred. And I'm not going to go into all the progress that happened after that, but think, for example, of new drugs that followed, statins, beta blockers, MRIs have developed. We now have organ transplants. We have the genome and all a host of things that have benefited medicine since that time. This is all just in the last century or so. In 1900, the average survival was 40 years. At the end of the century, it was up to nearly 80 years. It's a doubling. That represents a dramatic change. Medicine before 1900 had had no influence on life survival up until then, and it is now doubled. So the mind-body split worked in spades. We today see all the benefits of this. I've got 2 cataract replacements. My wife has 2 knees. People have kidney transplants, all sorts of things. We have benefited tremendously.
So that's curious. So we've talked about some of the medical advancements. What then is the problem?
Yeah, that's a good question, Rukia. So this worked famously, but remember, it worked on acute diseases and acute surgical problems. As those receded, many of which were cured, polio, smallpox, and the like, others controlled. And I told you, people lived longer. What happened was that mental health problems, which had always been there, but people died by the time they were 40, they're now living into their 80s. And so mental health problems are now becoming apparent as the most common health problem there is. But a second thing happened. Chronic diseases now replaced acute diseases, the ones you and I know so well today: heart disease, cancer, stroke, COPD, what have you. All of these chronic diseases are what medicine addresses today. Here's where the psychosocial comes in. previously ignored, and it worked okay with acute diseases and acute surgical problems. But now psychosocial is important because 17% of all chronic disease patients have a co-occurring mental disorder, depression, for example. It has to be treated or the physical disease does not improve. But it even goes beyond that. Lifestyle factors are what cause most chronic diseases. Cigarette smoking, alcohol, drug abuse, no exercise, overeating, and so on. All of these. These lifestyle factors are all psychosocial factors, the very thing medicine ignores. So that when our patients with diabetes or heart disease or COPD come along, we don't treat the lifestyle factor. We just treat the physical disease. Now, I want you to think a little beyond that.
Okay.
What would happen if medicine, and particularly medicine in the public health community, started to address these lifestyle features before the diseases occurred? That is, prevent these very diseases. It's known that 80% of all heart disease, strokes, diabetes can be prevented by controlling lifestyle factors. Prevented, not just treated, prevented. 40% of all cancers are preventable. And so here we have a situation. Medicine worked fine up through the last parts of the last century because it was controlling acute surgical problems and acute infectious disease problems. Now, mental health problems and chronic disease problems are there, which are almost entirely psychosocial. Medicine ignores that.
Interesting. So you think that might be what might be hindering change?
Yeah, I mean, here's the problem. I'll be quite blunt about it. Medicine has been brainwashed in the mind-body split. It worked, but it's not working as well anymore as it should because medicine has not recognized the change. Many people will tell you, students or a resident will tell you this, is I'm here to treat disease. I don't want that touchy-feely stuff. That's for the psychologist or the social worker. I'm here to treat disease. That attitude, and that's the so-called culture of medicine that has evolved, is we're interested in physical disease, and that's it. And basically, much of medicine today thinks things are going quite well. And that indeed we should be thankful for what we have. And I agree, we should be thankful. But there's more to it that now needs to happen. And there is another impediment that has evolved since the last part of the last century, the late 1900s. And there have become vested interests in medicine the way it is. It's the so-called medical industrial complex, which evinces this very culture I'm talking about. But it also is making tons of money off of medicine and our patients with things staying just like they are. And who are they? Hospitals, insurance companies, drug houses, equipment houses. These people are making a fortune off of things just the way they are. They don't want change. Think for a minute. I said 80% of all heart disease, stroke, and diabetes is preventable. What would happen to your hospitals if 80% of those patients were no longer there? There is a vested interest in keeping things like they are.
That is interesting. Having
It's sad,
said
yes.
that, having said that, I'm curious of what you propose we do to fix that issue.
Yeah, I mean, conceptually, at a fundamental level, the mind-body split is a theory or a philosophy. It needs to be replaced by what is called a systems view of life. All other sciences except medicine have moved from the reductionistic approaches of the scientific revolution to adopt a systems view of life. And what a systems view means in brief is that all parts of a problem and their interactions are considered rather than just one or two parts of the problem. Medicine today stays anchored just in the physical disease part, and it ignores the psychological and social. And so that's a reductionistic approach, focused just on one part of the problem. So medicine has conceptually arrested. It has not moved ahead like other sciences have. And this is a problem. This has been presented to medicine time and time and again. There are many people agree with what I'm saying today. This isn't unique to me by any means. They have been told time and again from the Institute of Medicine, have recommended training in mental health and psychosocial issues in all years of medical school and residency. Medicine does nothing. It is too brainwashed into its current circumstance. And that current circumstance is making money for a lot of other people. And so we are at an impasse. And what I'm recommending is that there needs to be influence on medicine from outside of medicine. Medicine is not going to solve this problem on its own. What we need is to get the public revved up, get them excited and angry about this problem, about how poorly they're being treated. Remember Ralph Nader, Unsafe at Any Speed, Rachel Carson, Silent Spring. They took on the automobile industry, which was blatantly irresponsible and creating unsafe cars. They changed Ralph Nader and Unsafe at Any Speed, changed that. The public can have an influence. Rachel Carson, industries were polluting every player and every place and didn't care. They were making money. They did not care. Rachel Carson came along and that changed. What I'm urging you now, all of us, is to come along and make the same complaints about medicine so that medicine itself changes. It is not going to do it on its own. And here's how I think it can happen. I think there needs to be a congressional or a presidential commission, maybe the Institute of Medicine, National Academy of Medicine, maybe even a private foundation needs to investigate medicine for how well it is adhering to modern scientific principles, which are a systems view of life for medicine. That's the biopsychosocial model. That commission will find just what I'm telling you today. And that is the leverage then for the people and the government to insist that medicine change. And they would probably use the carrot and the stick approach. It will cost a ton of money, but not near as much as we're losing today. If you prevented all the disease I'm talking about that's possible, it would save $1 to $2 trillion per year. So
Wow. You have,
changing what I'm talking about is
yes,
not going to cost near what will be saved, but it will cost money. And
yeah,
the carrot aspect of it is you pay them to do this, and you pay them
yeah,
handsomely. And for the medical institutions that don't do it later, they then become punished. It's the carrot and the stick approach. It can be
that,
done. It's what happened with the electronic health record. And so we need to get up in arms about what medicine is, or more specifically, is not doing. And so Micaiah, I'll turn it back over to you there.
Yeah, I was just going to say we are just running up on time because we want to leave enough time for a good group discussion because you have dropped a lot of thought-provoking information today, and we want to have an opportunity for folks to discuss. So we'll now transition to part two, interactive breakout groups, where you're encouraged to share your conversation with a few colleagues. Part two breakouts are not recorded. We hope you can stay for the entire hour and engage in part two conversation with colleagues. Just a few instructions. You want to see the prompts in the chat box. As you enter the breakout, we encourage you to start video and unmute audio. And as you introduce yourselves, we encourage one person to volunteer as an informal facilitator to support the group conversations and discuss the prompts provided in the chat, because there should be a lot of good group discussion based on what was shared today. You'll receive a notification when 10 minutes are left in the breakout groups. We will return to the main session for the final 5 minutes. Please prepare 1 to 2 key reflections to paste in the chat box in the final large group. Enjoy your discussions.